Now, so fiber fasting and fitness. So basically what I'm trying to teach you all is the things that give you a little bit of an edge, because a lot of the things that we don't know, we just don't know. So, so what I have to do is to empower you, because unfortunately, when we go to our doctors and we think that the doctors are the ones that are taking care of us, there are doctors that are taking care of you, but for the majority of people right now, with the way that medicine is, we're not trained to take care of you in the way of helping you prevent disease. The way we're really supposed to take care of you is to keep you out of trouble, is to keep you out of problems. But we've been trained, unfortunately, to wait till you get a problem, wait till you get diabetes or hypertension or sleep apnea or dementia, and say, okay, fine, you got this. And so we're great at diagnosing problems. And then the second thing we're going to do is get out a little pencil and paper, and we're going to write you a prescription for it. And that's just the wrong way to do it. As time has gone on, fortunately, a lot of physicians are pivoting to where we're talking about prevention. Unfortunately, not a lot of physicians are going down that road, not as many as we'd like. So the whole purpose of this channel is for you to take control of your own lives. You can take control of your own health, primarily because by the time you have to start seeing your physician and you start getting prescriptions, you're going down a tunnel that we don't want you to go down, because those prescriptions are primarily for just to treat your problems. It's not getting to the root of the problem. It is not getting the problem taken care of. It's basically making the big pharma companies richer, primarily because their goal is to get the doctor to write the prescription, and you're on the prescription for the rest of your lives. Most of you are probably, who are taking blood pressure medicine, probably think that you're supposed to take that blood pressure medicine for the rest of your lives. I would be willing to bet you that at least 90% of the people here who are taking blood pressure medicine were never told that the blood pressure medicine was a temporary fix, and that you had to do certain other things in order to get off the blood pressure medicine. Most of the people who are put on diabetic medicines were never told this is a temporary fix. Until we do these few things, then we'll bring you off the diabetic medicines. Chances are you weren't told that. Just for my own edification, just to make sure that I'm not talking out of the side of my mouth, how many of you guys who are on medication were told if their blood pressure medicine, dementia medicines, obesity medicines, or diabetic medicines, how many of you told that was just a temporary medicine and that they would help you to get that medicine to where you wouldn't have to take it the rest of your lives? How many of you were told that? Any information on that? So that's the goal, is that medicines are one of those things that, unfortunately, we found that they have side effects. And those side effects basically are things that affect us in the long term. So we're never going to live to our optimum health if we're on medicines, because just the side effects themselves can slow our metabolism down, can damage our mitochondria and things of that nature. None of the drugs out there really help build your mitochondria, which are the powerhouses of your cell. So let me go ahead and get into this thing. I'm going to give you a video pretty soon. But the questions that we always talk about is, what is GLP-1? Because the goal of our weight loss and metabolic reset program is kind of centered around this particular enzyme, this particular hormone, actually not an enzyme, hormone, is GLP-1. It's glucagon-like polypeptide 1. And glucagon-like polypeptide 1 is activated by certain types of foods. And those are the foods that we want you to take in, because the science has proved not only are they good for you as far as your micronutrient level, your machinery level, but your GLP-1 level. And the GLP-1 level, the reason we want that activated is does three basic things. Number one, it increases our satiety, meaning that we get full on lesser amounts of food. Number two, it decreases our cravings, which was a big thing for me. I had cravings for sweets, cakes, candies, potato chips, macaroni and cheese. I had cravings for all the refined carbohydrates, as a lot of us do. GLP-1 puts a stop on that, okay? And then there is some question about it, some controversy about it as to whether or not it increases our metabolism and all that. I'm not real convinced of that. I hadn't really seen any good data. And what I promise to you is that I'm going to give you advice based upon good data. But why do I want to increase your satiety? Why do I want to decrease your cravings? Because as it turns out, when we basically have cravings, we eat a bag of potato chips and we're still hungry. Our glucose curve goes up and then it goes back down. And when it goes back down, it goes a little bit lower than our baseline. That's when the hunger kicks in. Every study out there shows that your hunger level comes when your glucose goes down to below baseline. And what happens is that refined carbohydrates do that routinely. And the second thing that happens is basically what we're taking in is that the refined carbohydrates that then make you hungrier for the next bite. So you never really get full. So what you're eventually doing is taking in more foods than you need to. All that leads to increased amount of fat deposition. So what we want to do is have a product that reverses each one of those effects. And when we get that product, then it allows us to say, okay, fine, I'm not going to eat as much food. I'm full. My satiety is there. I'm full. But that's on a lesser amount of food. Now, the kicker to that is the science behind it is that you've got to have a certain number of calories every single day in order to survive. What we're doing is we're forcing your body to think that it's full before it reaches that number of calories that your body requires to survive for the day. Well, how is that possible then? How am I needing a certain X number of calories to live throughout the day, but you're saying I'm only taking in less than that? For instance, my body requires 2,500 calories a day. I routinely take in 1,000 calories a day. So theoretically, I shouldn't be surviving. My body requires 2,500. There's no ifs and buts about it. It's got to have 2,500 calories. If it doesn't get that, then it has to find alternatives. And the alternatives that the majority of us are struggling with is excess fat. Those are calories. That's our store. That's our storage of calories. Now, what happens if your normal weight don't have any fat and your body requires 2,000 calories a day and you're only giving it 1,000? Your body will still win. It says, I got to have that 2,000 calories no matter if you don't have any fat. What will it do? It'll break down your muscle. Well, most of us here aren't worried about that, right? Because we do have fat that our body needs to tap into. And that is our goal, all right? So just in case you were wondering about the physiology of it, that's it. If you don't have any fat to give, then I'm not talking to you. But if you have fat that you need to get rid of, because we all do, because that fat is usually in the wrong location, and that fat creates a lot of other problems that I don't have time to get into today. That fat creates inflammation mostly. It creates a lot of problems in our intestinal tract. It kills our microbiome. It kills our mitochondria. A lot of other things that I can get into the mechanisms of, but just kind of trust me when I say having excess fat is not a good thing. It's not just a cosmetic thing. It is not a good thing metabolically, okay? So that's why we want GLP-1 to be elevated, because it leads to that particular story. GLP-1 does the things that allows us to get rid of the fat. Bottom line, full stop, okay? The things that activate GLP-1 are the things that we're going to be talking about. That's what this program is. How can we get more GLP-1 activated? And then how can we do other things? Because GLP-1 is primarily the body's tool to get the fat and use the fat as an energy source. That's cool, but that's not all the problems that we have, is it? Some of us have dementia. Some of us have high blood pressure. Some of us have type 2 diabetes and prediabetes. Some of us actually have LDL cholesterol problems. So the overall goal is for us to take care of each one of those problems, not just to allow you to use your fat. GLP-1 does that. So The other foods that we're going to give you are the foods that, number one, activate the GLP-1. But the second and the most common food that we want you to really, really concentrate on is the fiber. Because that fiber is that product that has that vacuum type effect once it gets into your body, and I'll explain that in just a second. That fiber and then that protein, the reason we've got to have the protein in there is that our body just can't build anything without the building blocks. You cannot build a brick house without bricks. Our body's whole structure, the muscle, the bone, everything is built upon those bricks, which is the protein. Okay? So the fiber basically takes care of the metabolic problems that we have, the high blood pressure, the dementia, the things that are related to insulin resistance. Okay? And I'm going to go ahead and give you the answer right now because this is going to be an abbreviated talk. But the reason that fiber is able to do that is that we know, and this is what I want you to keep in the back of your mind, we know that insulin resistance is the core cause of most chronic diseases, including dementia, including brain fog, including hypertension, including sleep apnea, including diabetes, including cancer. We know, not all cancers, but we know that insulin resistance is a root cause. So you got to have something clear in your mind. What the hell is insulin resistance? Insulin resistance is when your body no longer listens to the insulin signal. Insulin is responsible for pushing glucose into the cells that need it. And what happens is it does that quite effectively over a period of time. But when you stimulate insulin all day throughout the day, the insulin doors on the fat cells and on the muscle cells don't open up. Let me clarify that. Your insulin responds to one thing primarily, and that's the level of glucose in your blood. First questions first, how's everybody feeling today? I have a little bit of insulin resistance going on because my family came in late last night around about 1 o'clock in the morning, so I didn't get my full 7 to 8 hours of sleep. And just that one night of lack of sleep can throw you back into problems with your insulin levels. But it's easily corrected. So maybe we'll talk about that a little bit, because sleep is probably one of the most powerful things that we never ever talk about. What happens when we sleep? Our growth hormone turns on. Does it mean that we're growing muscles at night while we're sleeping? No, that's not what it means. Growth hormone is that repair system. Our body repairs itself at night. And so basically when we're repairing ourselves, we have to have protein available. And we'll talk about how we get that protein available. We'll talk about how it is that we're aging. Because number one, we're not getting our sleep. And number two, we're not getting enough protein in order to have the building blocks in order for the body to repair itself using growth hormone. Don't want to get too technical, too confusing, but just suffice it to say, sleep is very, very important because certain things happen during sleep. And nobody's ever told you that, so you never knew that. So when you were younger, obviously you could go pretty much all night without sleeping. But as we age, and one of the reasons we are aging so rapidly is because we've had decades and decades of ignoring certain things that we need to do, like sleep. All right. But 2 o'clock, got up at around about 5. So I got 3 hours of sleep, all right? So I am now kicked myself into insulin resistance, which has a lot of implications. And so we may discuss that a little bit. We're getting more and more into the movement part of this protocol. Remember, our protocol consists of what we're putting into our mouths, all right, what we're doing with that stuff that we're putting into our mouths, and then what we're doing with our bodies, okay? So it's fiber, fasting, and fitness. The fiber part is important primarily because the fiber is doing certain things as far as our insulin spikes, okay? And the fasting part is primarily to keep our insulin levels low we want to always concentrate on the term insulin resistance, because the term insulin resistance means that insulin resistance, whether you know it or not, or whether you even care about the physiology behind it, just suffice it to say that most chronic diseases, including dementia, cancer, hypertension, sleep apnea, PCOS, Alzheimer's disease, all of these problems root themselves in insulin resistance. So how you get to learn that, that's the key. Insulin resistance is what we're always talking about. So what we want to do is figure out, okay, fine, how can we combat this insulin resistance? And that's the whole scenario. That's it. So we're combating insulin resistance by whatever takes insulin up. Insulin resistance comes from insulin being elevated all the time. And through the things that I'm going to talk about a little bit today is basically how we get that insulin resistance down. Because every time we eat refined carbohydrates or any carbohydrates whatsoever, we're going to get a little insulin spike. We've been concentrating on glucose spikes, which is okay. If we control the glucose spikes after we eat, then we're controlling the insulin spikes. Because this is how it goes. You eat something, you contain something with bread, pasta, pizza, French fries, whatever. You're taking the orange juice in the morning, you're going to get a glucose spike. If you had a continuous glucose monitor on your arm, you see your glucose go up, and then it'd come back down. And it'd come back down to a little lower level than you'd like, because then you'd get hungry again. That's another topic. But just stay with me for a second. So your glucose goes up. And you say, okay, fine, my glucose is going up. I need to control that glucose. Why? Because, again, getting back to insulin, insulin goes up as well. But it doesn't come down the same time that the glucose comes down. It stays up for 3 to 4 hours, all right? And what happens 3 to 4 hours later? We eat again. So that means that our glucose goes up again and our insulin stays up. So if you're eating, and even eating between meals, it's even worse. That's what we call snacking. And depending upon what you're snacking on, it can be a problem. So if you were to look at the graph of the normal, typical American, as far as how long insulin is staying up throughout the day, you'd be surprised, or maybe you wouldn't be if you were here. If you've been here, you know that insulin stays up all day long. Just because we're getting those insulin spikes, insulin comes up 2 hours, but, glucose goes up a couple of hours, comes down, but then the insulin stays up. The implications behind insulin staying up all day long is that insulin has a job. It has a job of pushing fuel into our cells so we can use it to make energy. But it only needs it at certain times. When we're giving it to it all day long, which is what I just said, our insulin goes up, our glucose goes up, but it stays up. So our insulin is up all day long. The cells are going to say, well, I didn't ask for you to be on all day. So what does it do? Your cells become resistant to it. And over a bunch of biochemical processes, that group of cells, all our cells throughout our body, including our brain cells, our fat cells, are beginning to say, listen, I'm not listening to you, insulin, anymore. And that's called insulin resistance. And that insulin resistance over years, over decades, causes diseases, high blood pressure, sleep apnea, cardiovascular disease, things of that nature. We get diseases based upon insulin resistance, okay? So everything that I talk about, our goal is to decrease insulin resistance. All diseases begin with insulin resistance. So if you have PCOS, it's insulin resistance. If you have diabetes, pre-diabetes, it's insulin resistant. Your blood pressure is elevated, insulin resistance. All right, so we know that insulin resistance is the key. That's the key term we're working on. So how can I reverse engineer that? You just take the glucose down. That's where the keto diet came in. That's where the low carbohydrate diet came in, because everybody realized that the problem was insulin resistance. So the insulin resistance insulin responds most strongly to glucose. So if you take in less glucose, less carbohydrates, keto, more fat, more protein, then your insulin doesn't go up so much. And so that decreases your insulin resistance. Does that make sense to everybody? Insulin resistance leads to diseases. What we have to do, and what we're all about doing, is to slow those disease processes down, including aging. Why do you think that I look like I'm 50 years old and I'm actually 92 years old? Just kidding, just if you're listening. But hopefully I'll look this way when I am 92. Hopefully I'll look this way when I'm 102. All right? And as long as I'm able to preach this and actually do it myself, it's possible. It's possible. And not only is it a hypothesis, it's a proven fact, because there are certain areas in the world called blue zones where people routinely live to be beyond 100 years of age. And they're routinely living to be beyond 100 and still working. And when you visit those folks, it's hard to tell that they're in their 80s, 90s, or 100s. All right? So that's what we want to do. Because living to be 100 is not that big of a deal, especially if you're 102 and you're in a nursing home. Who wants that? But if I'm 102 and I'm still able to get on a plane and go to the Bahamas, that's a big deal. If I'm still able to go on a cruise, or if I'm still able to play paddleball or tennis, that's a big deal, right? Because it's still about life. I'm still living life. That's what we're going to get to, all right? The protocol that we're talking about is fiber fasting and fitness. So let me ask everybody a question again before we get into our slides. The fiber does one thing. The fasting does another thing. So let's reverse it. What does the fasting do? Remember, our overall goal is to decrease insulin, right? So what does the fasting do? It lets the body rest. Fasting lets the body rest. Absolutely. That body rest is called autophagy, right? It's getting rid of all the bad products in the body, all right? Gives your body a chance to use stored fat for energy. Absolutely. Fasting gives our body time to create new mitochondria. Absolutely. Okay? And the way it's doing all those things is the central star of the show. It's lowering insulin. Because obviously when you're not eating, fasting, your insulin can't go up. Your insulin responds to food. It responds to protein very slightly. It responds to fat minimally, but it responds to carbohydrates. Even carbohydrates such as oatmeal or carbohydrates such as vegetables, it responds to that as well. Our goal is to keep that response as low as possible. And what you're going to have at your disposal is the tool to say, okay, fine. You don't have to have fancy tools like the continuous glucose monitor, because I can tell you, with and without the continuous glucose monitor, which I've used for certain experiments on myself to show you guys, I'm able to tell when my insulin levels are low because my glucose levels are low. How am I able to tell that? Because I'm not doing anything that raises my insulin. I'm not taking in ice cream and cake and things of that nature, okay? So, early on in my career, I was telling people, after surgery, you cannot take pizza, you cannot take pasta, you cannot take rice, you cannot take oatmeal, you cannot take sweet potato, mashed potatoes, macaroni and cheese, or you cannot take any of that stuff. Any of that stuff. I was putting you in food jail. And that wasn't a good place to be. Because people don't like being in jail. And they would always make an effort to break out of that jail. So they would take a little bit of pasta, a little bit. They would take a little bit of ice cream and cake, a little bit. Even though they knew that it wasn't the best thing for them to do. So what I've done over the past several years is basically make that transition to say people are going to do what people are going to do because that was the way that they were raised. We were raised on rice, and we're not going to stop eating rice just because Dr. Duncan said do it. Some people do. Most people don't. I'm not going to stop eating baked potatoes just because Dr. Duncan says I'm going to have occasional baked potato. And there are certain patients that tell me, Doc, I don't care what you say, you can do this surgery all day long. And sometimes I would refuse the surgery back in the old days. You can do this surgery all day long, and basically I'm not going to stop my life. It was a lifestyle. All right, so changing the lifestyle is still important, but I learned along the way that you didn't have to be as restrictive if, and that's a big if you did certain things first. If you're going to get into a car knowing that you could possibly have a wreck, you're going to put on a seatbelt to prevent that. And so what we found our seatbelt to be is fiber, protein and fiber. But fiber is the stuff that I'm going to show you that the viscous fiber, the type that gels up in your stomach, you put it in a little drink, you powder, or even if you experiment around with some psyllium husk and Metamucil, you put it in a little glass and you stir it and it turns into a gel. And it depends upon the concentration of it as to how fast it does that. That gel in your stomach is important, extremely important. And I would go as far to say that is the major part, the major responsibility of fiber. Everybody knows how fiber does for the bowels, right? But that's just one part of the fiber. That is one aspect of the fiber that we're talking about. The most important part of fiber that you never knew was that it's supposed to get into the stomach and gel. Why? Because that gel is like a magnet. That gel inside your stomach is like a sponge. What does this sponge up? It sponges up the glucose. So if you take that baked potato, if you take that macaroni and cheese, and you have a sponge there first, that sponge sucks that in. For the most part. Not all of it. You can't have a whole pizza. You can't have ice cream and cake and put that sponge in and expect it to do its total job. But I've done the experiment, and I've shown that if I wanted to eat a hamburger and french fries and a chocolate shake, that my glucose monitor stayed the same. And as long as my glucose stayed the same, my insulin levels would stay the same. All right? So that's what I'm going to be promoting to you now is primarily putting your seatbelt on. If I cannot tell you to stay away from the carbohydrates altogether, and I'm not even purporting that I do that now, but I am telling you, you cannot do it every day. You cannot eat pizza every day. You cannot eat rice every day. You cannot eat macaroni and cheese and pasta every single day. You just can't, okay? So we've got to meet in the middle of the road. At one extreme, at one point in time, I said, stay away from it all. And then the other extreme on your side, you would say, nope, I'm not going to do that. So those two extremes, we never could get together. And so people would regain their weight. And no matter what we did, whether it was exercise-induced weight loss, whether it was diet-induced weight loss, or whether it was surgical-induced weight loss, if indeed we were on two ends of the spectrum saying, okay, fine, now that in order to lose the weight, you got to stay completely away from these foods. That was me on this one. And then you said, no, I'm not going to stay away from. Then we always come back, basically, and you'd regain the weight. Now, someone said, okay, let's compromise. Let's come back to the middle. You can eat certain foods. You just can't eat them every day. Okay. All right. Somebody says, do you have a brand name for wearable continuous glucose monitors? There's the Libre, which is the expensive one. There's the one that I used and I showed you on this channel called Stelo, Stelo. That's a little cheaper model, but it's a good model. What you want to do is basically make sure that everything that you're doing is keeping your glucose levels stable, right? Within the green zone. It has little green things in those green things in between around about 85 to 120. Anything above 120, you're kind of spiking, okay, after you're eating. So if you're keeping yourself in that green zone, you're keeping your insulin levels down, and the longer you do that, if you go day by day by day by week, keeping your glucose levels in the green zone, you're going to get rid of some of your problems that are rooted in insulin resistance, because the insulin is not going to be going up, okay? Fibers need to be taken in, as far as duration is concerned, the rest of your life. And the thing about it is that you eat food every single day. That food should contain fiber every single day. Now, it's not easy, because the right type of fibers that form that viscous, you're not going to take in Metamucil every day. You're not going to, this doesn't taste very good. The ones over there in Sardinia, Italy are Arcaria, Greece, the blue zones where people are living to be greater than 100 years of age. Those folks don't have a whole lot of choice, because in their areas, that's all they eat all day long. That's all they have access to. Poultry, things of that nature are all very expensive, and so they tend to eat what they grow on their land, and they grow a lot of these fibers. And that's where we did the studies, which I found it a little interesting that we as Americans would go study certain type of fibers that we just don't have access to. So we put out hundreds, maybe even thousands of studies that said this type of fiber is great, use it. And we don't have it here. So I found it very interesting. And they would study all these populations and say, glucomannan fiber is good. Konjac root is what it's called. Beta-glucan is good. Oat fiber is good. The locust bean fiber is good. All these fibers are great, but we don't have them in here. They stripped them out because, again, those fibers require that you grow them, you eat them, you go through the next day. What we have here is what can survive on the shelf at Publix. So in order for foods to survive at Publix, the fiber, which is the kind of part that can go bad, fiber has to be extracted. The fiber has to be removed. So in order to make things cheaper, which means that they have to have a longer shelf life, we have to take it out. Okay? If I tell people to stay away from wheat, the wheat bread especially, and things of that nature, because it's a different type of wheat. They've extracted a lot of the wheat that people normally would have. Okay? And so, and the good wheat that we have. And so we did that primarily so bread could stay on the shelf for a good 10 days. I received the sleeve back in 2024. Can I get the bypass? Sure you can, but let me ask you why. Are you having reflux? All right. So yeah, the insurance companies will take care of certain problems associated with it. If there's weight regain, then we have to talk a little bit further, because I want to give you certain tools to help you lose that weight. Number one, to being what we're talking about today, fiber fasting and fitness. All these things are related to decreasing our levels of insulin. Where does fitness come in? Fitness comes in to us building our muscle. Our muscle is where our insulin is going to push the glucose. If the muscle cells are not insulin resistant, that's where the glucose wants to go, because that's where we get our energy from moving. All right. So if we condition our muscles to be healthy and receptive of that glucose, then basically that's cool. But when we have less muscle mass, in other words, we're not exercising, we're sitting on the couch watching TV, our losing muscle mass with GLP-1 analog drugs, the insulin has no place to put the glucose. So the glucose then raises up in the bloodstream because it has no place to go. It does have a place to go. It goes, the excess goes to fat, but the rest of it just stays in the blood. The body pushes as much as it can in the fat. And when the glucose stays in the bloodstream, the insulin level goes up. And then the insulin level stays up, and the disease processes begin. So you thought your high blood pressure was because grandmama had high blood pressure or daddy had high blood pressure. You thought that your blood pressure problems came from that. No. It came from the food that you ate that kept your insulin levels up. You thought that PCOS came from the fact that, okay, fine, I just happen to be the unlucky one where my estrogen and progesterone just is not acting right. They're not signaling to the other cells, and I got too much testosterone. No, it came from the insulin resistance because your glucose was up too long a period of time. Everything, and just as you might imagine, you can just Google it right now. What percentage of Americans are insulin resistant? Google that right now. What percentage of people in this country has the data shown that are insulin resistant? Almost all of us. 70, 80, 90%. Somebody asked the question, how does diabetes affect the process? Depending upon what you mean by the process, but the diabetes is a problem with insulin resistance. That is the purest definition of insulin resistance. Your body's cells are just not listening to your body's hormone insulin anymore. The two types of diabetes, of course. There's type 1 diabetes, where you are just not born, or you have an autoimmune process affecting your cells that make the insulin in your pancreas. That's called type 1 diabetes. Can't do anything about that. You have to take insulin the rest of your life. But the insulin that you're taking is the real insulin. It's not an insulin analog. You can take GLP-1 drugs and all that. But the type 2 is the majority of what we actually have. And the type 2 diabetes, the pre-diabetes, is what we're talking about. That is modifiable. We can cure that. And we've cured a lot of it. We've put it in a strong remission with surgery. We put it in a strong remission with this Fiber First protocol. And we almost always start our patients on the Fiber protocol before we ever even talk too much about, revision surgery. Because there's no point in doing the revision surgery, unless you're having a complication like reflux, if you had to sleep. But there's no point in doing the revision surgery if we hadn't modified what it is we're going to do. You're going to only wind up back in the same place. All right? So we got to. All right? Somebody asked the question, is my CRPs high because of the fat causing inflammation? Mm-hmm. Yep. I've lost 55 pounds and it decreased by half. My BMI is now 53. So, yeah, CRP, C-reactive protein, is an inflammatory cytokine. It's a gauge, just like our gas gauge, as to how our body is doing as far as inflammation is concerned. When it's high, it means your body is inflamed. And it could be for a lot of reasons. The most common reason, or one of the top 5 reasons, is the excess fat. Because the fat is a living, breathing organ, and it produces things that incite inflammation. But it can also be due to an unhealthy microbiome. One of the highest causes that we've just discovered in the last decade or so is that if we have leaky gut. Leaky gut leads to good bacteria in our gut, or bad bacteria in our gut, or any bacteria in our gut leaking out of our gut. Now, the bacteria in our gut is supposed to stay in our gut. It was not meant to mix and mingle with our sterile blood system and liver system and brain system. It was not supposed to do that. It's supposed to stay in the gut. It has happy in the gut. When we have leaky gut syndrome, either the bacteria, not commonly the bacteria, but the bacterial byproducts, breakdown, the endotoxins, they leak out of the gut because they're small micromolecules. The gut interior is supposed to be like this. The endothelial lining of the gut is supposed to be like this. When you have leaky gut, it does this. You see what happened? There are some gaps there. And of those gaps, on this side where my face is the intestinal part of the internal part of the intestine. On the other side is the sterile blood system. If I have bacteria being able to get through these little small pores, it's going to cause some inflammation. How do we correct the body? Again, we're rooting most of the things in fiber. Now, if you're able to go to certain areas of the world and get the 5 fibers that I'm going to be talking about, that's great. But I'm going to say they've already taken them out. But we're providing a way that you can get these good fibers, okay? And so we're talking about, again, glucomannan. We're talking about locust bean fiber. We're talking about the different types of fibers that form a viscous gel. So the number one thing that it does is this sucks in the glucose, keeping the glucose level stable so it doesn't give insulin spikes. The number two thing is that they've done studies that show how these types of fibers can actually suck in. The second thing that it sucks in when you take it is cholesterol. And they've had studies that compare fibers, these viscous type of fibers, with certain statins. Immediately when you go to the doctor, your cholesterol level is high, your LDL level is high. What do you get? You get a prescription. And that prescription is said it's going to bring your LDL down. All right? But let's not try that first. Let's try certain fibers that are cheaper, easier on the body, and basically don't cause all the side effects of the statins. We're going to try some of that stuff. There was a study that came out a couple of weeks ago, or maybe a couple of months ago, from New York University. And I wanted you to hear this because there's this big thing about GLP-1 drugs. And I want you to understand GLP-1 is not a drug. GLP-1 is a hormone that your body produces. The big pharmaceuticals made it into a drug called GLP-1 analog, receptor analog, okay? So it basically acts like the drug, but it's not the actual GLP-1. It acts like the drug. And it became all the popularity. But in what you're going to see on television about GLP-1 drugs is totally different than what we see as clinicians. And this study out of New York University that I'm getting ready to show you basically espouses that. It shows that in a clinical situation where you're doing a study, they show that semaglutide, they show that tirzepatide was able to get up to 18% body weight loss. Now, to put that in perspective, surgery gets you about 25% body loss. So if you weigh, let me see if I can figure out the math in my head. If you weigh 300 pounds, all right, and 300 pounds and you have surgery, 25% of 300 is what? 75 pounds. All right. So you're going to go 300 and you're going to consistently for the long term. This is what the study did. Not what happened in the first year, because some people will lose 100 pounds. They'll go from 300 down to 200 easily, but then they'll kind of gain back a little bit. All right. And we can control that too. But the study showed that surgery 25% pounds. So compared to the drugs like semaglutide, where you could get up to 15%, 18% body weight loss, and all the way up to the better drugs, tirzepatide, which you can get up to 20% body weight loss. So 20% of 300, you lose 60 pounds. Cool, right? All right. So that's what the studies showed in the study format. But what's out there in real life? When we started doing it, and when we started as clinicians, started treating patients because we saw all this great data.
Social media, the news, you name it, everyone is talking about these new weight loss drugs. But what if the most interesting story is about a new injection at all? Let's get into it. Yeah, you've definitely seen the headlines. Medications like Ozempic, which are part of a group called GLP-1s, have totally changed the game when it comes to how we talk about weight management. Okay, but what if I told you that a brand new study is suggesting that another, much older approach is actually almost 5 times more effective for losing weight? I know, that's a huge claim. And that's exactly what we're going to unpack. To really get this, we've got to look at this fascinating new study that came out of New York University. The researchers there decided to put 2 of the biggest weight loss strategies head-to-head, but in a real-world setting. So on one side, you have those GLP-1 drugs we were just talking about, the medications that work with your hormones to curb your appetite. And on the other side, you've got bariatric surgery, things like a sleeve gastrectomy or a gastric bypass, which physically change your digestive system. So yeah, 2 very, very different ways of thinking about this. And here's the really smart part. Instead of doing this in a sterile lab, they used actual real-world health records. They were super careful to match up the patients in the drug group and the surgery group by things like age, BMI, and blood sugar, just to make sure it was a fair apples-to-apples comparison. All right, so what happened? After tracking everybody for 2 years, what did the researchers find? Well, the difference was pretty staggering. Let's start with the surgery, folks. On average, patients who had bariatric surgery lost a whopping 25.7% of their total body weight. I mean, just think about that. That is a truly significant, life-changing amount of weight. Now, let's put that right next to the group taking the medication. They lost an average of just 5.3%. The difference is just huge. The surgery group lost nearly 5 times more weight. So, what on earth is going on here? That's the big question, right? Because you hear all these stories about people losing a ton of weight on these drugs in those perfect clinical trials. So why does this real world data look so completely different? Well, it kind of boils down to 2 main things. First off, as one of the NYU researchers, Avery Brown, pointed out, what happens in a super controlled, perfect clinical trial just isn't what happens in our messy everyday lives. The real world results for these drugs are often way lower than the 15 to 21% weight loss they see in those trials. And the biggest reason for that gap comes down to one single word: adherence. See, unlike surgery, which is basically a one and done intervention, the drugs only work if you actually keep taking them. And a lot of people don't. This study found that as many as 70% of patients stop their GLP-1 treatment within the first year. It could be side effects, the high cost, or just trouble getting it consistently. Bottom line, if you stop the drug, you stop getting the results. But of course, that one big headline number doesn't tell the whole story. To make a smart choice, you have to zoom out and look at the whole picture, including all the trade-offs. This breakdown is really helpful. So if we're talking about pure effectiveness, yeah, this study gives a clear edge to surgery. Same thing for permanence and adherence, for all the reasons we just talked about. But, and this is a big but, on the flip side, surgery is obviously way more invasive. The drugs are completely non-invasive. So you can see it's a major balancing act. And the benefits weren't just on the scale. The researchers found that surgery was also more effective at controlling blood sugar. And this is a really critical point, especially when you remember that these GLP-1 drugs were originally created to treat diabetes in the first place. One last piece of context that's important to know is where the money for the study came from. The research was supported by the American Society for Metabolic and Bariatric Surgery. You know, with any study, it's always good practice to know who funded it, just so you have the full picture when you're looking at the findings. So now that we have all this information on the table, what's the real takeaway here? What are we supposed to do with all this? Well, ultimately, the study doesn't really crown a universal winner. What it does is shine a really bright light on the fact that while one method might look better on paper, the best option is a deeply personal one. It really depends on your own health, your lifestyle, and what you're willing to commit to. Is it a lifelong medication or a permanent invasive surgery? And that really leaves us with the final thought. This research kind of reframes the whole debate. It suggests the most important question isn't simply, hey, which one of these works best? It's more like, which of these is the right sustainable tool for me as an individual? And that's a question that only you and your doctor can really answer.
What that study was actually showing, I love that study. Now, a lot of people on here who are obviously not in need of the surgery, but I wanted to address that issue because the GLP-1 drugs, as you're seeing the Oprahs on television and all that, they're talking about how miraculous this stuff is. And I just wanted to give it some pushback. Now, guess what? I use GLP-1 drugs, and I use them in a different context. I'm not going to put you on them for the rest of your life. I am not going to amp up the dose every month. I'm not. I use a protocol called the 3F protocol, the fiber, fitness, and fasting protocol. We start with that, and then as we reach plateaus, then I'll give a micro boost of the GLP-1 drugs. The reason I did that, and the reason I researched that, is because the side effects, the nausea, the vomiting, the suicidal ideations, all the muscle loss, all those things from the GLP-1 drugs came from the dose. So as we increase the dose, the side effects increase. And one of the most common things that I would get as far as my patients are concerned, say, doc, it stopped working for me. And I says, well, how did that happen? Well, I just didn't take it as much. It's the adherence, because it made you feel blah. It took away your hunger, but you stopped enjoying the day. And so the GLP-1s were affecting the GLP-1 receptors in the brain, in the dopamine system, in the pleasure system, and it would block pleasure. Pleasure from exercising, pleasure from doing certain things, pleasure from eating, pleasure from drinking alcohol, pleasure from smoking. Those are the good things. But just generalized blocking pleasure is not a good thing. So that's why people would stop taking them. That's why this study showed that 70% of people stop taking them within the first year. If you're going to spend thousands and thousands of dollars on something and stop taking it in the first year and regain your weight, what's the point? But like I said, getting back to my point, is that I use it because it does have a benefit. You keep it at a smaller dose while at the same time incorporating the fiber, the fasting, and the fitness protocol, you've accomplished something. Because what we're doing with the fiber is telling your own body's GLP-1 to wake up. Because it is no question that all the studies showing that most people who are overweight or obese, their GLP-1 levels are suppressed. Now, whether that happens because of all the foods and the seed oils and all we eat, nobody's really studied deeply into that yet. Or at least they don't have the answer. They've studied it. So we know that your GLP levels are suppressed. That's why these drugs make a big impact, because the GLP-1, after you take the drug, really goes way high. And so you stop the hunger, you start losing weight. And the problems is because of the dose. 40% of them lose muscle mass. That's a problem. I've had a patient, maybe more, but I've had a patient that didn't have diabetes, that then took the drug to lose weight and developed diabetes. Well, how'd that happen? Well, they lost 40% muscle mass, and what did I just tell you? What that muscle mass does. That muscle mass sucks up the glucose so it can produce energy for that muscle to move, right? You got less muscle mass, you lose 40% of your muscle mass, then that glucose has nowhere to go. If it doesn't have anywhere to go, it's going to go basically cause the insulin levels to rise up. And the insulin levels to rise up is insulin resistance, the pre-diabetes thing that we were talking about, and the diabetes. So the solution I figured was basically don't just poo-poo GLP-1 drugs, but use them strategically. Don't do what industry is doing by saying that everybody needs to be on it who is overweight or obese, because that's what's happening. And don't say that it needs to be on it forever, and just microdose them while at the same time you're training your own body through fiber, through fasting, and through fitness to make the healthy lifestyle that we need to do. So that study was pretty cool. The challenge of the GLP-1 agonists, Eric, what they are, we know what they are. The GLP-1 analogs are not the hormone that your body's making. What we're going to be trying to do is amp up your own hormone. Basically, bariatric surgery, you all know what that is. I reduce the size of your stomach, and it activates your own body's GLP-1. So gastric bypass, the sleeve, activates your own GLP-1. The icing on top of the cake is it forces you to eat a little bit less. But over a period of time, your stomach expands. Your stomach gets bigger. But if your GLP-1 is still activated, you're still keeping the weight off. There's a lot of people who are on this call that I know that their stomachs have expanded, but their weight loss, they hadn't regained their weight. And it's because their GLP-1 is naturally activated. Not super activated by taking the GLP-1, naturally activated. So when you naturally activate GLP-1, you don't get the nausea. You don't get the vomiting. You don't get the Ozempic face. You don't get the loss of pleasure because it's your own GLP-1 working with you. All right? So that's what surgery does. Now, what I'm going to be talking about is what we can do short of surgery to get that same effect. And that's what I call that 3F protocol with the microdosing of GLP-1. I will keep you on GLP-1, only the first dose, the 2.5 milligrams, for about 1 month to 3 months once we reach a plateau. So we start you on the fiber first protocol first, and basically, if indeed you reach a plateau, say, Doc, it's gone a couple of months and I hadn't lost any weight, Okay, so we'll boost this. The low dose is a booster. So like jump starting a battery, it's a booster. It is nothing that I'm going to keep putting you on and keeping you on for life. Okay, that's the point. So this study compared what we're actually seeing, and that's why I love the protocol that I've developed. That protocol basically just kind of goes along with this thing is that I wasn't seeing that the GLP ones where I was getting that 22% weight loss. Initially, yes. But then as time went on for a year and 2 years, they weren't getting that. As opposed to the surgery group where we activated the GLP-1 normally, if those patients continued the fiber, the fitness, and all that, basically they kept the weight off because they had their own GLP-1s. So that's why there was that five-fold difference in the bariatric surgery group after 2 years. After 2 years, 25.7%. Okay, it maintained it the entire time because we start out at about 30%, then it kind of comes down to 25%. These start the GLP-1 medicines. The studies start in a controlled environment where they're seeing their doctors, they're getting the blood work, they're doing. That's where they got their data from in their controlled environment. They had people coming back to the clinic every month getting calls from the nurse practitioners. And that's where they got that data saying, hey, we can get up to 21% excess weight loss of your normal weight. Excess weight loss, your total body weight. And 18%. It was up here in that group. But when we got into the real world and we followed for 2 years, it dropped down to 5.3%, a five-fold difference. Kind of cool. So explaining the gap, this is the clinical trials where we got the original numbers, which is what Big Pharma only wants you to know, that 18 to 21% with tirzepatide, 22% with tirzepatide, that's in the good old clinical trials, 15 and 21%. The reality is, you follow those folks in the real life, in the real world for 2 years, it drops down significantly. So, and one of the main reasons is that 70% of those patients discontinue because their dose is too high. They're getting nauseated. They're losing pleasure. The affordability is changing. People can pay for it. Sometimes the insurance company is taking care of it. So the affordability wasn't necessarily one of the factors here. But the majority of people stopped taking the drugs because they felt, it's not working for me. So I'm be interested in just look into the chat box. How many of you all have tried GLP-1 drugs? That's a question posted for me in the chat box, okay? So the GLP-1 agonist versus bariatric surgery, there's no question about the duration. But, this is a big but, surgery is invasive. GLP-1 drugs, taking a pill is not. We always want to go to the pathway of least resistance. Popping a pill, giving a shot once a week, not a problem. We'll all be willing to do that. But, again, the thing is that we got to figure out what our ultimate goal is. So, I found this technique that's the middle of the road, and I'm doing this ongoing study to say, okay, fine. The GLP-1 agonists, only 5% of people are actually losing the weight that they're talking about losing, whereas 25% with the surgery. But they're two opposite ends of the spectrum. One is completely non-invasive, one is invasive, all right? What if we found some place in the middle? The same kind of process I was talking about before. I'm meeting everybody in the middle. So we're starting people on the fiber fasting and the fitness protocol, and then we're micro boosting the GLP-1s. And I'm doing that study to see if I can get close to what we're getting with surgery for the long term. So we're going to do this study for 2 years, and I just wanted to announce that's going to be one of my coolest studies that I've ever done. All right. It's just that I love this part when people are transparent. They say, this is a study out of New York University, but it was funded by the American Society of Metabolic and Bariatric Surgery. Whether that had any impact on it, and I always tell you that it does. Who funds it? Just like all of the studies done on GLP-1 drugs were funded by the GLP-1 companies. So if I'm going to be if I'm going to disclose transparency on one side, I got to disclose it on the other side. So this other side, this study that we just looked at was funded by the ACMBS. Whether that changes the data, nobody knows. So what we have to do is to get independent people repeating this study to give us the true numbers. And if they're the truth, that'll come out in the wash. So this is what this is saying. In future studies, we will aim to identify what healthcare providers can do to optimize GLP-1 outcomes, because that's the key, GLP-1. Identify which patients are better treated with bariatric surgery versus GLP-1s. Because everybody wants GLP-1 because it's non-invasive. But there are certain people that don't have the time for GLP-1s to work, certainly not at a 5% level. I have several people that have lost weight on this fiber fitness protocol, but they still need surgery. And the reason is because if their levels of CRP, like somebody mentioned, or their levels of sleep apnea or prediabetes are critical levels, or they're sick and they don't know it, then I would, after I do their workup, I said, well, yeah, you can continue to try this non-invasive protocol, but you got a high incidence of having a heart attack or stroke or diabetic complication or something of that nature. So there are certain people that need to have surgery, and there are certain people that can indeed go down this other path of non-surgery. Give more information about this study. It's an exciting study, but I want to make sure that you guys, the fiber fitness protocol, you'll be seeing that in social media pretty soon. You'll be seeing it. We'll give that information to you because there are 5 fibers that you're not going to get here in the United States, but I want you to have access to them, and I'm going to show you how to get those fibers, okay? We have everybody's email. We'll be sending you stuff out about the protocol, because the protocol is, again, one of those things that we want you to do without drugs. Now, if we have to throw in, like I said, a GLP-1 drug in there just to kind of edge it along, we'll do that. But we'll do that primarily because we want you to get to the level of what we get with surgery without me having to cut on you. My goal is eventually not having to cut on anybody.
Listen, Dr. Titus, your strategy, when you say fiber, fasting, and fitness, you know I'm always going to show up to pop in on that fitness component, because that's what we do. We do fitness because we understand we're trying to maintain our muscle, right? And we're trying to maintain our muscle because guess what? Muscle takes up, I'm going to give him a little nugget, Dr. Titus. Muscle takes up less space than fat. So if I got a pound of muscle that takes up this much space, and you got a pound of fat that takes up that much space, guess who's gonna look better in their clothes? The person that has a pound of muscle. So when I pop in here to do fitness, it's all about keeping and building muscle, because muscle is really what stimulates that metabolism anyway. So we're gonna try to keep it tight. Everybody ready to keep it tight? So it's the holidays. I'm gonna just show you guys 1 or 2 quick exercises, and these are just total body exercises that you can do anywhere. So you know how we do it. I want everybody to stand up first, okay? And I know we've been sitting for a while, so I want you to just loosen up a little bit. We want to start here. We want to get some blood circulating. Yes. It's about getting that heart rate up a little bit. And so we're going to start with a little stretching. And I want you guys to put your hands right above your head. Stretch it straight up. And what we're going to do today is just one exercise where you actually just come forward like this. Come all the way forward. Yep. And then come all the way up. Just like that. So we're going to start with 10 of these, stretching forward and coming up. And why are we doing this? Because we're trying to work your core muscles, your abs, your lower back, your shoulders. There you go. You're going to give me 10 of those. And you guys know. Count it out. What's that? 3. Come on, there you go. And this is where if you actually have some hand weights at home, you could add them to your hands. If not, I want you to actually ball your fist up nice and tight. Just like that. We're going to give me 3 more. There you go. 3 more. Yep. 2 and 1. Now keep those hands straight in the air. So we did the upper body. That was 10. So now we're going to do what? We're going to do the lower body. So hands are still tight. And now I want you to give me 1, 2, 3, 4. And if you need to at home, you can always hold on to something. Hold on to the wall. Get your balance. But what I want you to do is just pick your legs up. And if you can't get your knees that high, just lift them up as much as you can. Because what we're really trying to do is we're trying to work the lower body. And guess what? These are your biggest muscle groups. So this is where you want to have more what? Muscle than fat. Remember, we got that. Muscle takes up less space than fat. So we work on our big muscle groups. We set a 10. There you go. Want to get to 10. Keep it up. Keep it up. I know you're there, ladies and gents. Keep it up. Keep it up. Keep it up. Keep it up. Good job. How you feeling out there? Now shake it out. Shake it out. Yep, shake it out. Now we're going to repeat that again. So we're going to do it again. So ball your fist nice and tight. There you go. Yeah, you thought we was over. Above your head. Now I want you to bend at the waist. Yep, and then come up. This time when you come up, can you guys give me a little energy? 1, 2, 3, 4, 5. So this is what you call a heart rate blast. It's called HIIT training. So this is just a way to add a little intensity to a workout. Yep, I'm just adding a little to it. A little bit more, 30 seconds. There you go. There you go. Now keep them up there. Now lower body. Ready? Let's go now. Lower body. Right back to what we did before. 1, 2. There you go. 3, 4, 5. You got that? So every week I try to show you a movement and I try to take you through it. So let's go back. We're going to do this about 3 or 4 more times, right? So we're fists are tight. And remember why our fists are tight? Because what takes up less room?
Muscle.
Muscle. Fists are tight. Hands above you. Bend at the waist. We're going to do 5. Get up there. There you go. 4. Stomach and belly button tight. 3. 2. And 1. Come on up. And what we're doing, this is where we do our blast. 30 seconds. Come on.
You got an old man version of this?
Oh, yeah. You can do it like this. You can do it like this.
Okay.
You do it like this. You're just trying to keep those muscles tight, you know?
Okay, there we go.
Yeah.
I got the temptation.
You got that?
I like that.
And so guess what? Now you got your legs up, so hold on if you need to. So basically what we're doing here is it's called the compound exercise because we're trying to work multiple body parts, right? We did that upper body, we did the heart rate, and now we're doing the lower body. Everybody got it? You guys want to try this again? Compound exercises, real easy. Okay, so I'll show you one more time. Ball those fists, hands above your head, stomach is nice and tight, bend at the waist, and then bring it up. There you go. Bring it up. Bring it up. Give me a good set of those. There you go. Now take those arms straight up. Now give me the lower body half. Lower body half. There you go. Use your balance. See, we're doing stuff that's requiring the total body. There you go. There you go. Now that you got it, now we're ready for that heart rate boost. You know what? Come forward for me. Come on. Come on. Dr. Titus, I'm coming for you right now. Look. There you go. There you go. There you go. This is just getting that heart rate up. There you go. Give yourselves a hand. That's what we do, ladies. We gotta figure out how to do this total body.
So Andrew, they asked the question about what exercises this suggest for flabby skin, and then also another question came in about, so we do this on Saturday, but to give them some homework.
Yes.
When is the next time you want them to do this particular exercise? And
yes, you know what? We're gonna put together a real plan for you guys, and so I got it. I'm gonna get it to you, Dr. Titus, and we're gonna blast it out. So it'll be just like a little guide, like, hey, I want you to do this during the week, and then on Saturdays, we're gonna have a live session, and we'll go from there. Okay?
Sounds
But
good.
it's essentially gonna be simple exercises you can do at home. Total body, we got you covered. You guys can of course, if you want to get to me sooner than we get it to you, you can always reach out to me. Look me up. I'm gonna have my folks sending out information. Well, we have the email, so we'll send out. We'll create it and send it out to your whole group, and then that way they'll have. This is gonna be my Christmas present. I'm gonna send them a little at-home guide for you all for your group, and then we'll just keep seeing you guys on Saturday.
Okay.
You can follow me at IG at GT Body Beautiful, or you can email me info@getbodybeautiful.com. And then, like I said, we got your information, so we'll get something put together and we'll get something sent out to you, Dr. Titus, okay?
But this is just the beginning. You continue to come back. We're going to continue to build this, and then eventually we're going to be able to get stories from you guys about how this process, whatever process it is, whether it's the surgery, the 3F, the fiber fitness and the fasting protocol, or the fiber fitness and fasting with a little micro boost of GLP-1, or even the surgery. We want to hear how you guys have done, because I think I'm a true believer in this particular type of study protocol. We're going to shock the world. Okay? So I appreciate you guys being here, and I will see you next weekend. And have a very, very happy Christmas, okay? Very Merry Christmas to all y'all.